Particular to
Yeah, what is the formula you use for calculating? She was about to tell that.
In males, it is 50 kg plus 2.3 kgs for every inch above 5 feet.
So 2.3 multiplied by
Every inch.
inches minus 60.
okay, sir.
So 2.3 multiplied by, in brackets, height in inches minus 60. That is 60 means 5 feet, as you said. So, and for females,
43 kgs plus 2.3
not
times.
43, it is 45.
40.
Yeah, 45 plus 2.3. So this is the tidal volume you will be using. So you don't go with actual body weight for calculating the tidal volume. And you will be going in for lung protective ventilatory strategies, isn't it? So what we will do is, we will stop at this moment. We'll continue for about half an hour tomorrow, or less than half an hour, for this particular patient regarding the obesity and anesthesia. And afterwards, we'll finish the geriatric patient. Is it okay? Because it is now 7 o'clock. So just before that, I think anything in the chat box, we can just... So Sadhna has asked for ABG, that already said. Yes, definitely ABG is very important. Any other... nothing is there in the chat box, I think. Okay, till now, any doubts you have, what we discussed? So briefly we can, or what we can do is, no, okay. So Sadhna is asking one more thing. What about preoperative weight loss? So definitely you can ask for a preoperative weight loss. That is definitely is going to help in all obese patients, but very difficult to, if the patient is posted for a major abdominal surgery and very elective, major surgery, elective totally, then one can go for, preoperative weight loss. Definitely it is going to improve the pulmonary conditions also and cardiovascular status also, and even many times even the glucose intolerance can also be reduced. So that one can always go for. But in this particular patient, so because he is having acute symptoms of calculus cholecystitis, so and we don't have much time, so there won't be much time for weight loss as a preparation for taking up these patients. Otherwise, yes, definitely one can go for a weight loss also as a preparation. So what we do is, tomorrow first thing, whatever the doubts you have, we'll just have the doubts cleared. You may have many doubts, especially whatever till now we discussed. And then afterwards, we'll continue with our discussion.
Yes.
Okay, so we'll be required to discuss about the maintenance part, plus the fluid requirement in these patients, and problems of laparoscopic surgery in a patient who is morbidly obese, and the post-operative management. So whole thing we can just discuss in less than 30 minutes. And another 1.5 hours will be sufficient for a geriatric patient posted for cataract surgery. Okay. Okay.
Thank you so much, sir.
Behind is it?
Current is off.
Sir, now it's finished.
Now it's fine.
Right.
And now it's better, much better.
Yes.
Now you power,
Covers come
Yes, sir.
restored. Okay, okay. So anyway, just Anup and Neena. So just want to ask you about any of the doubts. So first few minutes, we will just clear off any doubts if you have, or if your friends have any doubts, and then we will go into we'll continue with our discussion. It's almost finishing, maybe a few more minutes of discussion. We had come up to the maintenance phase of this particular patient. You could intubate this patient without much problem. So though it was a difficult airway, and of course all obese patients should be considered to have difficult airway, and especially if an obese patient with OSA. That's why, history of OSA is very, very important. And once the patient has OSA, it is always better to go for an awake fiber optic intubation. And that is always better. Either you can go for awake fiber optic, or even you can use video laparoscope and then awake oral intubation also you can do. You need not have to go for awake nasotracheal intubation using fiber optics. So that is always there. So, but if you want to use a video laryngoscopy, then a proper, nerve blocks have to be, done first before attempting a video laryngoscopy. But for fiber optic, you don't require to, go for a proper individual nerve blocks. You can even nebulize the patient with lidocaine 4%, and also you can 2% or 4%, whatever it may be. And then you can also run some Dexam infusion to slightly make the patient more cooperative. And that is majority of the times. And then you can even go spray as you go when you are using fiber optic scope. So you can keep, syringe loaded with 2% or 4% lidocaine. You just go there near the vocal cords, spray the vocal cords, and spray the epiglottis, wait for some time for at least 1 or 2 minutes, and then you can proceed. So that is also one of the easiest things one can use spray as you go technique also for these patients wherein you have not done a proper individual nerve blocks. So those things are very, very important. So in exam also, you'll be asked, this is also sometimes kept as a difficult airway. All obese patients. Because obese patients, thyroid patients, burns contracture patients, usually on, temporomandibular joint ankylosis. So these are some of the patients which are kept for difficult airway short cases. Okay, so any doubts regarding yesterday's discussions? Anybody has expressed any?
This is actually a general doubt, sir. It is actually in one of the articles or literature it was saying in pre-op, we counsel the patient, you have to abstain them from smoking 4 to 6 weeks prior to bariatric surgery and alcohol withdrawal for 1 to 2 years. So does that persist for our case as well for lab obese patients?
No, any case for that matter, if he is a chronic smoker, it is always better to make him abstain from smoking for 4 to 6 weeks. That is ideal because the smoking will have a lot of effects on the respiratory system and also can produce postoperative pulmonary complications. And one of the most common problems with smoking is, the mucociliary transport mechanism is inhibited by smoking. So it is the mucociliary transport mechanism which is very, very important for bringing the secretions from the lower respiratory tract to the upper respiratory tract so that the patient can cough and bring out these secretions. So this will take at least about 4 to 6 weeks for regaining the patients to regain back the mucociliary transport mechanism. It takes about 4 to 6. Of course, the other advantages are also there, like hyperreactivity of the airway will decrease. That also takes some time to decrease. And the carbon monoxide problem, the carboxyhemoglobin, of course, that can be reduced by just stopping the smoking by about 24 hours. But, once the patient stops smoking, at least for 4 to 6 weeks, there are a lot of advantages. But if we can stop smoking for 6 months, so there are more advantages. And what they have found is the postoperative pulmonary complications are same as the patient who has never smoked, and in those patients who have stopped or abstained from smoking for more than 6 months. So that is one of the reasons, ideally speaking, anyway, bariatric surgery is not an emergency surgery. And you also allow the patient to, get his weight reduced also by taking, nutritious but decreased amount of calorie intake also, and then doing some more output. So he can definitely, and also using some of these medications to reduce the, body weight. Also, can be used, and that 6 months the patient can be prepared. Alcohol gives a lot of calorie, one, and that can increase body weight. Second thing is it can also produce problems to the liver. Alcoholic hepatitis is very, very common. So by asking the patient from abstaining both alcohol and smoking before bariatric surgery, definitely is going to help. So can prevent many of the post-operative complications. That is, can be done. But in your patient, because he is being posted for lap cholecystectomy, and it is not a elective procedure because he is having acute symptoms. When he is having acute symptoms, the chances of him going in for gallbladder complications can be high. One thing is he has got a large stone. Almost you have written 15 by 10 millimeter stone. So it can obstruct the cystic duct. Once it can obstruct the cystic duct, or it can, by chance, it can pass through the cystic duct, definitely it is going to block the common bile duct and the patient will end up with obstructive jaundice. The second thing is, if it obstructs the cystic duct, there is always a chance of having the patient going in for rupture of the gallbladder. So that becomes an acute emergency. So at least now you have sufficient time, maybe 2 or 3 days, to prepare this patient and then take up. So definitely in this patient, you may not be able to wait for 6 to 8 weeks as a regular elective procedure. So you may have to take up early, but at least if you can abstain smoking for at least 24 hours, the carbon monoxide problem, carboxyhemoglobin problems can be reduced. Of course, he is not a regular alcoholic. He takes alcohol occasionally. That is. Okay, any other doubts?
So there is one scoring stratification, obesity surgery risk stratification, mortality risk stratification score. So that can be used for all the patients or only for patients that
yeah, you can definitely use for all the patients, and basically for bariatric surgeries where the surgeries can be prolonged. So in such surgeries, you can go for morbidity, mortality scoring systems for these obese patients. Otherwise, routinely for short surgeries like lap cholecystectomy, you don't require much. Because we have seen this laparoscopic surgery, as I was telling you in our previous discussions, for morbid obesity in olden days, maybe about 15, 20 years back, morbid obesity was an absolute contraindication for laparoscopic surgeries. Like there were few absolute contraindications for laparoscopic surgeries maybe long back. One is morbid obesity. Second thing is severe ischemic heart disease, severe COPD, pregnant patients, and hemolytic jaundice or hemolytic anemias. So these 5 were absolute contraindications when laparoscopy was initially started in India and everywhere throughout the world. But now they are the basic indications. They are the first indications for laparoscopic surgeries. And any patient who requires early mobilization in the postoperative period, who should not have more amount of pain, and who should not be given much of opiates in the postoperative period for control of pain. So these are the patients laparoscopy is ideal. But of course, intraoperatively for anesthesia, laparoscopic surgery adds more problems for us as anesthesiologists. But considering the postoperative, the advantages, so laparoscopic surgeries are ideal in many of these patients, like geriatric patients, morbidly obese patients, ischemic heart disease patients, COPD patients, and even pregnant patients when they are posted for non-obstetric surgery in the mid-trimester. So all these patients, they have a lot of advantages. Like I want to tell you, one of my relatives he was now about 86-year old. Last month he underwent laparoscopic cholecystectomy. He has all kinds of problems. He is obese. He has got ischemic heart disease. He has got respiratory problems. So he has had 4 stents in his coronaries. So all multiple problems are there. Dyslipidemia, metabolic syndrome. So you name it, majority of, but he underwent the surgery. Next day he was discharged home. He's hale and hearty now. And just consider for the same patient an open cholecystectomy. So you would be in the hospital for about 5-6 days, bedridden, so much of pain. You have to use so much of analgesics for such patients. And definitely the morbidity and mortality would be very high. That's how, for obese patients, that is how, because of the introduction of laparoscopy, bariatric surgeries have become very popular, isn't it? And robotic bariatric surgeries are also becoming very, very popular. Of course, that has added more difficulties for us as anesthesiologists. That is always there. So, okay. Any other doubts? No, when I ask you the doubts, you need not have to ask the doubts what you have for that particular case. If you ask any doubt in anesthesia, we can have a brief discussion so that it is just, warming up for you people. So that, you can relax and then afterwards you can take part easily with the discussion. So you can ask any kind of doubts what you have. Every day you'll be having some doubts in your day-to-day routine anesthesia management, isn't it? So those things also we can discuss. Okay, so I think now it is, what is the time now? I think 5. Yeah, 5:08 already. Okay, we'll start with our this thing. So we were because you said that after intubation, so you would go for from 100% oxygen, what you were giving, and also para-oxygenation you were using, like trive or nasal oxygen of 10 to 15 liters. So once you have intubated, confirm that the both sites are equally being ventilated, normal positioning of the endotracheal tube. Now you have said that you will switch over to oxygen and air. And I think in general, you go for low flow anesthesia in your hospital. That is routine, isn't it? So, and also you said that you are using AMSORB. So AMSORB with the sevoflurane, no problem. It won't produce any compound A. So you can go for very low flows like 350 ml or 500 ml with low flow anesthesia technique, even using sevoflurane. So even in obese patients, you can definitely go for low flow anesthesia technique. It is not contraindicated in obese patients. But here, one thing is, now once you have started your maintenance, so how much of tidal volume you're going to keep and what is the respiratory rate you're going to have before positioning of the patient? Because we have not positioned the patient, and we will have to talk briefly about the problems associated with positioning for laparoscopic cholecystectomy. So how are you going to manage the ventilatory part?
Tidal volume of around 6 to 8 ml per kg.
Per kg.
Always, when you are answering in the exam, don't say the range. Because, one thing you should realize that you are actually practicing or actually doing the case there inside the operation room. So what you don't think that, okay, 6 to 8, isn't it? You keep either 6 ml, 7 ml, 8 ml like, isn't it? So you just be very clear, very specific when you are answering. Okay. So for this patient, already we have discussed about the optimum body weight for calculating the tidal volume. That is plus 2.3 multiplied by height in inches minus 60. So that weight only should be used for calculating the tidal volume, because all lung volumes depend on the height, and it does not depend, and they do not depend on the girth of the patient or body weight of the patient. It is always height that matters. That is why that formula is used to calculate the body weight for calculating the tidal volume. So based on that, you can keep 7 ml per kg body weight. So what is very important again here is you have to go for lung protective ventilatory strategies. Nowadays, this is one thing is always there in the exam also. You'll have to say, I would like to go for a lung protective ventilatory strategy. So what is this lung protective ventilatory strategy? Is always low tidal volume. And you ventilate with low tidal volume because you are mainly bothered about the volume trauma. and like in ARDS, isn't it? So here in these patients, again in obesity, you have to go for a low tidal volume because they have got a restrictive lung disease. The problem is restrictive lung problem. So better not to go for a higher tidal volume. So lower tidal volume based on their height. So that is one thing, 7 ml per kg body weight. Okay. And then what about the respiratory rate?
We will monitor the ETCO2.
Yes, very good.
Ideally keep
So
14 to 16.
yeah,
And then
35 to 40 ETCO2 you have to maintain, isn't it? So just to maintain the ETCO2, you can adjust to maintain the minute ventilation, you can adjust your respiratory rate. So that is always there. And what about the IE ratio?
1:2 is what we ideally keep.
Yeah, this is enough. 1:2 is enough. So he's not an doesn't have so much of a problem as far as his smoking is concerned. He doesn't give any history of chronic bronchitis. So if he was a COPD patient, definitely you would have gone for a longer expiratory time, you know, to prevent air trapping, isn't it? So this is okay, 1:2. And the main problem in these obese patients is, you know, they have a small FRC, they have got an increased closing capacity. And that is why, you know, you took so much of precautions in giving nasal oxygen, para-oxygenation and all these things because they rapidly desaturate. And intraoperatively also, the atelectasis of the alveoli is very common when you are ventilating with only these kind of ventilatory strategy with a low tidal volume and higher respiratory rate. So in order to maintain and increase the FRC, so what is very important is here you have to reduce the closing capacity, you have to increase the FRC. Otherwise, the patient developing intraoperative desaturation and postoperative desaturation is very common. And again, patient can even develop postoperative pulmonary complication because atelectasis, postoperative atelectasis, lung collapse, and end up with respiratory failure. So he's just come for lap cholecystectomy. He should not end up with respiratory failure in the ICU, isn't it? So how are you going to manage intraoperative, decrease closing capacity, improve the functional respiratory capacity?
PEEP, sir.
Yes, adequate PEEP.
Adequate PEEP should be.
Now, what you should tell in the exam is you would like to go for lung recruitment maneuvers with PEEP. PEEP alone may not be sufficient. Lung recruitment maneuvers may not be alone sufficient. So you'll have to have a combination. You have to expand all the alveoli which have collapsed. And especially when you are giving 100% oxygen, many of the alveoli would have collapsed. That is mainly because of absorption atelectasis. So you'll have to, you know, open these alveoli. So in a patient who has got a restrictive lung disease, unless you use a recruitment maneuver, these alveoli cannot be opened. So once they are opened, you have to maintain that patency of these alveoli. So for opening the alveoli, you require recruitment maneuvers. And for maintaining the patency of these alveoli, you require PEEP. So that is how, you know, you should always think about. And then, so how do you do this recruitment maneuver for these patients?
So you have to keep in the bag mode and you can.
And you need not have to go into bag mode. So you can go for a pressure controlled ventilation. You can increase the pressures.
So okay, sir.
Respiratory
Should be
pressure.
released for 30 centimeters of water for.
So usually their requirement is itself is a higher, you know, peak inspiratory pressures because, you know, small lung. So naturally they require the low compliant lung. So they require higher airway pressures initially itself. So for recruitment maneuvers, at least 10 to 15 centimeters increase you have to go for. So majority of the times you may have to go for 45 to 50 peak inspiratory pressures and hold it for about 15 seconds and then bring back to their original whatever the pressure you had kept, about 25 centimeters of water with PEEP of 10 to 15 centimeters. So that's how you always maintain. And frequently you have to do these recruitment maneuvers because if you just do once, there is always a possibility again they may collapse. So frequently say once in 20 minutes or 25 minutes, at least 3-4 times during this surgery, you can go for recruitment maneuvers. And especially in many of the modern workstations, you have these recruitment modes are there. inspiratory recruitment modes, expiratory recruitment modes. They have, like in ICCS square, you have in Zeus, and many of even the Drager Perseus. You have these separate modes are there. You just have to opt for these modes intraoperatively, and they do the recruitment. The mode itself will go for recruitment, and then you can switch back to your maintenance mode. So that will be very easy many times. So if you have high-ended workstations, that is one of the advantages there. Okay, so recruitment modes are very important, and now the patient has to be positioned. So what is the position that is adopted for this particular patient?
Ideally, they say the surgeons prefer reverse Trendelenburg position with the left tilt.
Yeah, left lateral tilt with reverse Trendelenburg at least about 30° centigrade.
And
This
they have to
position,
manage.
with this position, what are the effects of this position on the respiratory system, cardiovascular system?
There is
Blood pressure will
Effects of
reduce.
the
increase in series. There is increased pooling of
So respiratory
blood.
center first. You talk about respiratory system and then go for, because this patient has got a restrictive lung disease. So, and plus pneumoperitoneum, isn't it? So further pushes the diaphragm high up. So further producing more restriction as far as the descent of the diaphragm is concerned. So now if you are putting this patient into head-up position, is it advantages and disadvantages?
There are chances that the ET2
ET2
will
might
be
come off.
above the level of the carina.
Carina.
So basal.
No, those complications definitely you expect, and then endobronchial intubation is more common. And this endobronchial intubation occurs whenever pneumoperitoneum is done. It is not for this particular patient with head-up position. That is a problem with the pneumoperitoneum. Even because the lung compliance comes down, even chances of pneumothorax are also there, and endobronchial intubation is there. Those things are common for laparoscopic surgeries, which we have already discussed before. So what I'm thinking is, now is an obese patient. Now in an obese patient, head-up position, they tolerate better, or head-down position, they tolerate better?
Head-up, sir.
A head-up position, definitely for their respiratory system. Because, now the FRC will increase with head-up position. That is, this is the reason why you wanted to keep this patient with a head-up position for even pre-oxidation.
Yes.
And it head-up with CPAP of, 8 to 10 centimeters you had adopted for pre-oxidation, so that you wanted to improve the FRC and decrease the closing capacity. So once you make this patient to go for a 30° reverse Trendelenburg position, so definitely his lung functions will improve. His FRC will improve, his closing capacity will come down. So probably his saturation will improve, his PaO2 will improve. So as far as the respiratory system is concerned, definitely a head-up position is much better. You just compare the female patient is there, morbidly obese patient posted for laparoscopic hysterectomy, and lithotomy with steep head down. You just may not be able to ventilate such patients. It will be very difficult. Pneumoperitoneum plus the diaphragm is pushed high up, and head down position further decrease in the lung compliance. So it will be a very difficult, plus the lithotomy. Definitely lap cholecystectomy, this head-up position is much better, and definitely there will be much decrease in the respiratory system problems associated. Okay, so for respiratory system, this is ideal position. Okay, what about the CVS? Nina was tell something.
Peripheral pooling will be more, sir.
Yeah, peripheral pooling of blood will occur, so decrease venous return.
Allowed venous return, sir, and decrease in cardiac output occurs.
Or decrease in cardiac output. So the another thing about these things, because the peripheral pooling of blood, what the other complication they can develop?
Thrombus, DVT.
DVT, isn't it? So DVT. So you'll have to use DVT prophylaxis for these patients intraoperatively. Also, you can have pneumatic, intermittent pneumatic compression technique. Definitely, you may have to use. That is very important. so that will improve the venous return also. And the second thing I was, when I was telling you about the lung